Welcome to another episode of NBM Talks, a series of the Narrative-Based Medicine Lab, where we speak with individuals who are working at the intersection of literature, medicine, and health. Our guests are writers, clinicians, scholars, artists, and advocates who are pushing the boundaries of what's possible in the field. Together we discuss how we can engage with narrative-based medicine principles and practices in creative and diverse ways. We hope you enjoy this episode. Welcome to NBM Talks. I'm Damian Tarnopolsky, the creative lead at the Narrative-Based Medicine Lab. Today I'm joined by John Launer from our International Advisory Board to discuss his career as a physician and practitioner of narrative-based medicine, as well as exploring some of the questions facing the field more broadly today. John Launer is a retired family physician and family therapist, now working as a full-time educator and writer. He has taught internationally on the application of narrative ideas and skills to medical practice, including patient encounters, supervision, and teamwork. His posts include Honorary Lifetime Consultant at the Tavistock Clinic in London and Honorary Associate Professor at University College London. He's the author or editor of 10 books, including Narrative-Based Practice in Health and Social Care, Conversations Inviting Change, and he writes a regular column for the British Medical Journal. For more details, you can visit his website at johnlauner.com. John, it's a pleasure and an honour to have you with us today. I believe you're joining us from suburban London today.
I'm joining from suburban London. It's a pleasure an honour for me to be here too.
Well, thanks very much for being here. I was wondering if we can start, if you could tell us a little bit about your background as a physician and as an author, with your interest in reflective practice. How did you begin to work in what we call narrative-based medicine?
I did my first degree in English literature before I changed over to doing medicine. I then became a general practitioner, a family physician, and I felt rather a fish out of water, both as a GP and as a doctor, because I got an arts background and I felt rather overawed by all these scientists around me. I became interested, particularly in working with families and in family therapy. So I decided to do an additional training as a family therapist. And to my amazement and delight, I found that family therapists took the idea of stories and narratives very, very seriously. So for a while, I considered leaving family medicine and being just a family therapist. And then gradually it dawned on me that there was a fantastic opportunity to train family physicians and primary care clinicians to use ideas about stories and narratives in their own work. And that's really, I mean, I was already in my mid-40s by then, but it's really when my career took off. And it coincided with the birth of the narrative medicine movement, or what we call the narrative-based medicine movement in the United Kingdom. I was close to both Tricia Greenhalgh and Brian Hurwitz, who edited the first book with the title Narrative-Based Medicine. Of course, then Rita Sharon came along some years later and wrote her book on narrative medicine. And suddenly I'd found a home, a niche. And together with a colleague at the Tavistock Clinic where I'd trained, we created a method of training in essentially narrative-based practice, the application of narrative skills and ideas to everyday clinical encounters, as you mentioned in your introduction, consultations with patients, training encounters, learning, teamwork, everything. And that's really what I've devoted my career to ever since.
And what would you say are some of the key lessons that you've tried to impart as a practitioner, or that you come to see now as most significant?
I think one is that while ideas from narrative medicine are really valuable and really important, a conversation, a consultation is not the same as a written text. One needs to adapt all the learning from narrative medicine that comes from literary studies, sociology, psychology, etc., to a very different context, which is actually when somebody walks into your consulting room and says X, how do you respond? What do you do then and there in the moment? So it's using the ideas and skills, but it's adapting them in a very different way to what's happening immediately in the room. And I think the second is the necessity to marry together what we call the narrative and the normative. And by the normative, I mean the norms of science, of evidence, of legislation, of regulation, all the things that are required of doctors and health professionals. You've got to be able to understand the world in terms of stories and respond to it in terms of stories, but you've also got to remember to be an expert, to be safe, to believe in science, and somehow to marry the two.
I feel like I would like to ask you about 40 questions about
Okay.
all the things that you've just said because they're all fascinating and valuable and relevant to us. I'm kind of curious though, if for our audience you could make this a little bit more concrete or give examples of times when narrative has been significant to you or times that you used it professionally, obviously without breaking
Yeah.
any rules of confidentiality, but just if you can make a story out of the importance of storytelling.
I think it happens all the time, really. I mean, the case I often quote is of a young woman who came in and said, I've got four problems. Now, if you regard that as a list of problems in a classical medical sense, you already feel overwhelmed. But if you regard it as a story, you start from a different position. So I asked her, what's the fifth? And she told me. And no family physician will be surprised to learn it was the most important problem. It was the one that either unconsciously or subliminally she'd hoped to be able to talk to me about. And she talked to me about it. We never got to the other four problems. We didn't need to. So, if you like, that's drawing on the idea that the statement, I've got four problems, is it's an utterance, it's a form of words. And if you respond to it as a form of words rather than medical list, you take a completely different attitude to it. Now, there's a video I often show of me working with an actor who is playing a patient with severe facial pain. And near the beginning of the consultation, I say to her, what are you hoping to get from this consultation? And she says, as many patients will in that situation, I want the pain to stop. And I kind of absorb that a bit and say, fine, would you mind telling me a bit about yourself? So if you like, I distract her from the world of problems and the world of pain to a world of people and who are you as a human being? And then I get to ask her questions like, can you tell me who's at home? And it turns out that she's had, as an adult, she's had to move back home because of losing her job, partly connected with the pain and so on and so forth. So we've moved from the normative world to the narrative world. Now we then move back to the normative world because clearly I have to know what specialist she's seen for the pain, what the diagnosis is, what medication she's on, what operation she's had, and so on and so forth. But if you like, I've turned the conventional medical consultation upside down rather than doing what medical students are taught to do, which is you find out about the hard stuff, and then as a kind of concession to being a human being, you then ask about what's called, the family and social history. I I turn that upside down. I actually think unless I understand the context around this person, I'm not going to make sense of what their pain means to them. So I mean, and this is the kind of thing that happens every day, really.
You know, one of my colleagues at the lab, Sarah Kim, I think frames things in similar ways to you. That she says that what are dismissed as soft skills, the kind of
Yeah.
humanistic skills, are in fact core skills. It sounds to me, tell me if I'm wrong, but it sounds to me that what you're describing is what you've written about elsewhere about letting stories breathe, about
Yes.
letting a dog off a lead and seeing
Yes.
where the stories go, which is a wonderful metaphor for what we're discussing. What are the challenges or the difficulties that practitioners face when they try to do this, and how can those be met?
I think one challenge is the kind of inner voice that's saying, this is not what doctors do. One of my books I called How Not to Be a Doctor. And the title is paradoxical because I think the starting point is to let go of all the ideas that you have about what doctors should and shouldn't do and to return to being a human being instead. So that's one thing. I don't think I've ever taught a session in my entire career where somebody says, but what about time? I've only got 10 minutes for consultation, 7 minutes for consultation, which is my standard answer is, have you any idea how much time physicians waste by going down uh, dead ends that have no utility for the patient simply because you've been taught that this is the list, this is the litany of questions you have to go through, and the patient's absolutely bewildered because they don't know why you're asking those questions. You haven't explained your logic to them. They don't understand why medical training leads you to ask one set of questions rather than another. And they're bewildered that you're not asking them about their lives. So that we waste a lot of time and we alienate patients by having, I call it like questions like planes waiting to take off at an airport rather than ones that are improvised like jazz, to change the metaphor, where you're responding to the tune that you hear from the other person with an entirely unique question for that conversation.
But I imagine for people who are used to order and lists and control, that can be challenging emotionally as well to start to improvise or to start to play along with somebody else.
It is. And, we say you've always got that to fall back on. If you want to feel safe, if you want to feel you're putting the patient at risk by not asking those conventional questions, fine. If somebody comes into your consulting room with peritonitis, yeah, narrative is not going to heal them. You do need to ask those questions, but the problem is that an awful lot of doctors treat everything as if it's peritonitis when 99 times out of 10 it isn't. So if you start with the narrative, the normative will come out anyway. In the course of this video consultation with my patient with facial pain, she tells me her entire medical history in the course of telling me her story because she knows I'm a doctor. She knows I'll need to hear it. She wants to share it with me, but it comes embedded in a very, very rich personal story instead. So I pick up everything I need to know, including the drug she's on, without actually asking those medical questions.
I think the what you're describing, this going back to being human or this unlearning certain aspects of
Yes.
practice sounds well, it's very similar to what we do at the lab, but it also sounds like a vitally important way of thinking about it. The I'd like to switch gears a little bit if we can and move away from the clinic to speak more broadly about these fields that we're
Yeah.
engaged in. Um, Thinking, I mean, you mentioned earlier some of the differences between I guess we could call it British or continental approaches to narrative-based medicine, the American development of narrative medicine. We see ourselves in Canada as being, I think, somewhere in between and
Yeah.
trying to learn from both and use elements of both. Um, Looking at the field or the fields as a whole these days, how do you see them as having developed productively and profitably? What is missing? What are the challenges? What questions should we be asking ourselves as narrative-based medicine people? Um, yeah, what's the state of play and what's next?
One element in the equation we haven't mentioned is narrative therapy or narrative based therapy. I think in our approach in the UK, we draw both explicitly and maybe um, just by having absorbed ideas from Michael White and David Epston's approach to narrative therapy in Australia and New Zealand, where we see exchanges between clinicians and patients, clients as a kind of restoring of their lives. I don't particularly like the word restoring, but it's a very nice idea that what is going on in any clinical encounter is that patients are being given the opportunity to think of their predicaments from new perspectives through new lenses. Now, I think possibly the field of narrative medicine as a whole hasn't drawn enough on that tradition of narrative therapy from the Southern Hemisphere, and I think we could do that at all. In terms of the challenges we face at the moment, I think we don't yet, well, speaking for myself and the team of people I work with, I don't think we have even begun really to engage with the challenges of AI. Um, I have just begun with a group of colleagues in the United Kingdom to start to think about what uh, AI enhanced narrative medicine might look like. Now, we already know that AI can uh, often diagnose better than most physicians. It can often give advice and guidance better than most physicians. It's beginning to reach the stage where it can even ask better questions than most physicians. And we've been experimenting with programs here in the UK where it's actually quite uncanny what good questions Chat GPT or DeepSeek or other programs can ask patients and also ask learners. I mean, AI is a very, very good supervisor. You take a complex case to AI, and it will take you through a graded series of questions that really get you to think.
Are
I mean,
these
these are not banal questions.
are they narrative questions? Are they more diagnostic?
You,
What sort of questions?
you can ask it to ask narrative questions. You can actually give it a prompt that says, here is a complex case involving several family members, several professionals, a number of different clinical and social dilemmas. Can you generate the kind of questions that a practitioner informed by narrative medicine might ask? I mean, that's now a perfectly standard uh, for AI. I fed a case into AI yesterday, into Chat GPT, and I fed a case where there was a peculiar response from a patient. It was a narrative shared with me by a colleague, and I said, what would a psychoanalyst ask? What would Michael Barlint have asked? And what would medical educator John Launer ask? And it spat out perfectly good questions that would fit with each of those particular perspectives or frameworks. Now, we've got our job cut out now to outdo that.
Yeah, it sounds like there's a kind of, I don't know if it's an exciting or terrifying possibility of narrative without people.
Well, I don't think it's narrative about people, and I think uh, it it's inevitable. I think it's unavoidable. I think we're in a space now where patients and learners will laugh at us if we're not competent in dealing with this and going beyond it. I mean, the average medical student, the average intern is way ahead on all of this and would expect us to be able to use it and to go beyond it and say, okay, what's the added value of me being a human being? What's the added value of me being a flesh and blood person with 40 years of professional experience behind me? Because if I can't use that, yeah, then I am redundant.
No, but I think that's a wonderfully important question to ask and a place to stand on. You know, what is the added
Yes.
human
Yeah.
value? Um, we're almost out of time. It's been uh, enlightening and replenishing to speak with you. Just I was wondering, this can be a narrative medicine question or just a more general question. I think our audience would be curious. What's on your nightstand these days? What are you reading, or what would you recommend to our audience
Well,
today?
I, I read all sorts of weird and wonderful things because I read at random, which is I might just happen to hear of something or a friend tells me, and it's completely random. It can be from any field at all. It might be. I mean, recent books I've read have been about trees and Nelson Mandela and all kinds of completely unrelated things because they happen to cross my path. But the book I would highly recommend is written by two British GP colleagues of mine, Rupal Shah and Jens Ferl, and it's called Fighting for the Soul of General Practice. The Algorithm Will See You Now. And it's addressing precisely the issues I've been talking about, which is what is the added value of human beings in this new world we face? And I would very highly recommend it. It's the kind of book I wish I'd written and actually couldn't have, because these two colleagues are a generation younger than me, and they have quicker minds, and they've come up with an absolutely brilliant book. So I'd really recommend that to anybody who's in the field of healthcare.
Well, fantastic. Thank you for that recommendation. We'll leave a link to that and on our site alongside the recording. And thank you very much for this conversation today. As I said, it's been both enlightening and encouraging and replenishing and thought-provoking. Well, both, all those things for me, and I'm sure it has been for our audience as well. John Launer, thank you very much.
Thank you very much. Thank you. And I felt really stimulated by it. So much appreciated.
Thank you. Thanks for listening. If you enjoyed this conversation, check out many other episodes. And if you're interested in learning more about narrative-based medicine, visit us online at narrativebasedmedicine.ca for more great content and to explore our upcoming offerings.